Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Dr. Michael Agus, Division Chief of Medical Critical Care at Boston Children's Hospital, where he is also the co-medical director of the biocontainment-unit. Welcome, Michael, and thank you for joining us.
Thank you, David. Great to be here.
I'm interested in speaking with you about the COVID-19 pandemic in particular, but also about managing a pandemic or other disasters in general. As the director of an ICU at a Harvard teaching hospital, how do you think about the before, during, and after of an event like this? And to begin, in terms of the planning from a layman's perspective, I'm thinking about planning for surge capacity. I assume you have a surge capacity model that accounts for seasonality and other sorts of surges, like some sorts of local or natural disasters, but also pandemic situations. So overall, how do you take surge capacity into account when you're planning over time? And how is it looking today? What kind of data goes into that planning, and has that changed over time? How do you get ready for an event that's sort of coming down the pike?
Yeah, as you point out, that's a big question, and there are significant components that are incorporated really over years. There's no way that a given plan is ever fully baked and ready for any eventuality. Rather, we build kind of a basic infrastructure and then modify in real time. The most relevant planning we did for COVID-19 started about 4.5 years ago with the Ebola outbreak in West Africa. Our institution put up their hand very early on and said this is a capacity that we need to have for children in terms of care capacity. And as we prepared for the possibility of taking a patient with Ebola into Boston Children's Hospital, we realized that we needed a broader infrastructure to support that, and we founded the biocontainment-unit. It's essentially a virtual unit, meaning it doesn't exist till we activate it. And then we move and we take over 2 rooms in our ICU, put up walls, and we physically create a single bed unit. Associated with that is a team of volunteer doctors, nurses, respiratory therapists, dialysis nurses. And that team has a shadow schedule continuously. While they have their main job working in specific units in the hospital, they all have a secondary schedule that if activated, they would leave their primary job. Those holes would be filled in by the regular unit staff, and they arrive on the biocontainment unit to deliver care. This team has been training very frequently at the beginning, and then we backed off to quarterly training, with the primary training associated with delivering care in personal protective equipment, PPE. That gear is very constricting. It's very specific. Putting it on, taking it off, those steps are very precise, very well planned, and benefit from a lot of practice and training. And while we maintained this unit, we realized over the years that we would have the ability to use this training in various sorts of outbreaks. But we had always thought of it as related to this physical unit, which again only exists when we turn it on. That was really, really important training for our institution to have in place. And the other prior training in terms of a surge capacity specifically is really tabletop exercise oriented. While we do have incredible variations in patient volume according to one viral season or another, we also have incredible variability in elective surgery planning. And so during the winter, if you're a child who has some multiple medical problems and needs various surgeries or procedures, you would do everything you possibly can to stay out of the hospital in the winter so you don't get infected by the virus of choice that season. Whereas the summer, especially time off from school, is the high end of the surgical elective volume. And so the winter, we have a decrease in the surgical electives, and we essentially fill that with whatever virus is in season at that time. So there's a natural balance in our hospital, swapping out medical for surgical on different floors. And that 9.5 times out of 10 is sufficient to manage the seasonal volume. Overall, our hospital has been kind of oversubscribed. The ideal occupancy in a hospital is considered generally to be 80%. That allows for cleaning of rooms, moving in and out of patients. And we exist around 90, 91, 92, depending on the season. So we're a little too full. And so we're in the process of building a new building to increase our total capacity by about 25%, from 400 to 500 beds roughly. So surge planning within the context of seasonality, we have under control. And I should have mentioned also the emergency department has the ability to increase their beds and convert from, just seeing patients for a few hours. A whole series of beds can be converted to overnight status. We use the PACU, the recovery area from the operating room, as another surge location and keep patients overnight depending on seasonal variation there. And we have procedure rooms. So there is some built-in surge capacity that we use in and out over the course of the usual year.
You were faced with the 100-year flood, so to speak. So there is some built-in flex and surge capacity. How are you able to adjust that given COVID-19?
The dramatic surge capacity we're looking for here consists of taking over areas that would, even in a usual surge, would be preserved for mostly surgical patient flow. That's the switch we have in our armamentarium to turn off elective surgeries. And what that does is clear out the surgical floors, it clears out the surgical ICU beds, and opens up the PACU and operating rooms to be locations for care for patients. We've never had to take over the entire PACU, but we could as a care location. But mostly it opens up the floor in the ICU in a sufficient way to contain the surge. The most extreme version is the rooms are built to take 2 patients per room. The head walls are built and our booms in the ICUs are built with enough pressure gas flow and suction and electrical supply to handle 2 patients in a room. So that would be the extreme surge. On the outpatient side, there's another surge capacity in terms of ability to move clinics, open up tents, see patients in conference rooms, that sort of thing. And that is built, described, but again, not yet turned on, primarily because of the unique aspects of COVID-19 as they relate to adults versus kids.
You started to touch on the equipment issues, the equipment needs, in addition to pure issues of space and staff preparedness. I wonder if you could say more about the equipment needs. We've all heard of concerns about ventilators, numbers of negative pressure rooms available, personal protective equipment, as you've alluded to, and we've spoken about sort of preparedness for biocontainment broadly, and I'm wondering how all of these issues are focused now in terms of pandemic preparedness.
We were incredibly fortunate to have the focus that we had, I have to say, on the biocontainment unit historically. As we got closer to COVID-19 and it became real, we chose, for obvious reasons, not to activate the physical unit that was built to care for 1 patient. But what we did do is deploy the members of the BCU team. Primarily, that is an extraordinary group of nurses who've been incredibly well trained over the years. And we deployed them to the emergency department, to the floors, to the ICUs where these patients were being admitted. And they served as just-in-time trainers, coaches, mentors, what we call site manager, where your job is to observe care being delivered, point out flaws, coach people so that they conduct themselves in exactly the right way, put on protective gear in the perfect order, take it off slowly in controlled fashion. They literally block the room when there's an emergency and don't allow people in unless they have on appropriate gear. These are critical and widely accepted principles of pandemic care when you're dealing with a contagious and potentially lethal pathogen. But those subtleties are very hard to teach to the broad population in a hospital unless you're able to deliver teachers to the bedside. And that's what we were able to do with the VCU. And it's been an extraordinary success. In terms of the gear itself, again, we've become very familiar with these components and the team was able to teach that to the huge hospital staff over time. And we've had good success because in getting going, we've always maintained our own store of PPE for this kind of surge, whether it's Ebola or otherwise. And we have offsite storage that we've kept up the entire time. and we're able to access and maintain a steady supply. As we've moved into high usage, it turns out for whatever reason, gloves have never been impacted and are readily available and are replenished on essentially a daily basis from our supply chain. The gowns we chose to use very deliberately are very effective, and they are reused and laundered. So as long as the laundry supply chain stays intact, we are good on gowns. The face shields we've chosen and the goggles are cleanable and reusable. So again, we need a supply to get everybody one set and occasionally replacements, but that is intact. And so all we're left with is really the respirators or masks. Because of our ability, our focus on the VCU, we've had very good stockpiles that we've maintained. We've made sure people are fit tested, meaning they know what size they're supposed to use. And if they can't use the size, we've been using PAPRs, the powered air purifying respirator, as well for these several years. These are for people who don't have a good fit with the N95, or they have beards or some facial anatomy that doesn't lend itself to a good seal with a regular N95 respirator. Those have been the major issue in the supply chain, as has been published nationally and worldwide. But the fact is that our stockpile has allowed us to stay on top of that. And we moved to establish a reuse protocol, which had already been written and planned for this Ebola event, which again, just put us weeks ahead to be able to have a plan that we'd already designed. And all we had to do is flip a switch to turn it on. And that meant we reuse it over the course of a day or a shift. And then the next reuse protocol, which we're about to turn on actually this week, is to decontaminate those masks in-house using ultraviolet radiation and have a optimized logistics system that is able to deliver your mask back to you after decontamination. People appreciate the idea of decontamination, both bacterial and viral, but they still don't want to use someone else's mask. And we get that, and we've designed a system that can get your mask back to you within an hour after you're done using it, and then it's waiting for you clean when you arrive at your next shift.
So, Michael, it sounds like you're operating a neighborhood dry cleaner on an industrial scale. Get my shirts back in an hour?
Yeah, it is quite the logistical operation, and it has been striking on how important it is to, A, get the details right, and B, make sure all of the users understand that we got the details right. Walking into the room of a coughing, febrile, sick patient with suspected or known COVID-19 can be daunting, and one needs to have confidence in your personal protective equipment. And we don't generate that confidence by making promises and generic statements. We have to really show people that we know what we're doing. We know how to get them in the right gear. We've used CDC guidelines. We use science to the extent that it's developed in this area. And we do an enormous amount of conversation, of presenting data, of admitting where there's an absence of data, and partnering with all these different members of the team to engender confidence in the system that we've built. It is a very delicate, arduous process, but if you don't take that aspect of the process seriously, then people do not have the confidence, and they can become very unsteady in the care that they deliver.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Michael Agus at Boston Children's Hospital. Michael, you're at a teaching hospital at a research institution, and I'm wondering about research during a pandemic. Do you have any sort of pre-planning done or pre-approved protocols that can allow you to have some observational studies done effectively through the course of managing a pandemic so that we can capture some valuable snapshots and learn from the experience later?
We can't design a protocol for a patient population that doesn't yet exist, but we can design them and improve them incredibly rapidly so that we can have it ready to be useful for the patients as they arrive. And that's exactly what we've done. We've constituted all sorts of committees of experts to design, to approve, to evaluate, to prioritize, to collaborate, to perform prospective interventional trials, to record the retrospective data and share it with our peers. We've already embarked in numerous collaborations, and how one chooses those and designs those is obviously of incredible importance. The general approach we have embarked upon is for the retrospective trials recognize that children are affected very much in the minority. And so the only valuable data we can really share is not one-offs and two-offs and even 10-offs, but it's collaborating with our peers, our pediatric peers across the country. And we've already signed on to a study that looks like it will go into one of the major journals to describe the first month's worth of patients for the rest of the country and the rest of the world that has seen very little published on children with COVID-19. There is a full range of illness, as it turns out, where children are certainly among those that will have the severest form of the disease. However, the vast majority of children are very minimally infected. And in the other trials, in terms of interventional trials, you would really only use these medications, which all have side effects, and we don't know exactly what the right combination is. And even if with the best combination we can muster, is that can be enough to stop the disease or turn back the disease in the sickest patients. But you can't possibly ask those questions in the tiny number of children that are affected in the severest way. So for those interventional trials, we have chosen to date to partner with the adults, where they will have the vast numbers of severely affected patients, and to put our very few severely affected children in those adult studies makes more sense than conducting tiny studies with just a handful of children. So those are the sorts of decisions we need to make on the fly, but we have an incredibly deep knowledge and experience and protocols and infrastructure in our institution and our partner institutions to get these analyses done incredibly quickly, efficiently, and try to get to the best decision to add the best knowledge to the care of patients.
So what you're describing is an incredible broad-based network, not only of clinicians and institutions, but really a data network that allows for the integration of data from multiple locations in order to develop a usable data set. As you said, this particular disease is not that common among the pediatric population, so you're needing to aggregate data across vast distances and numbers of institutions. And that really triggers for me sort of another broad question, because to me that seems like a relatively new thing that one can do effectively. And broadening from the research question to the management of disease, the management of pandemic or disaster events, I'm wondering if you can reflect on how the approaches have changed over the course of your career. Can you give us a sense of how these things have changed over time, given the different sorts of tools as well as knowledge that we have at our fingertips today?
The collaboration worldwide to share knowledge in this particular disease has been absolutely mind-bogglingly extraordinary and outstanding. It is incredible. I have been on conference calls, video conference calls with Chinese clinicians speaking from their call rooms while caring for patients and putting together PowerPoints to summarize their 5s and 10s and 50 patients to show us exactly what they found and what has worked and what hasn't worked. We've been conducting a weekly phone call with clinicians in Italy in the region of Bergamo, which is one of the hardest hit towns in the world for COVID-19. And these clinicians take time out of their shifts. They clearly walk in from the unit, take off their PPE, sit down and speak to us for an hour and tell us what they've seen and what they've experienced. And it is extraordinary international coordination and collaboration on the national side. And this is repeated across fields. It's true in pediatric critical care, where we've started a twice a week phone call with 250 ICU leaders across the country and at this point, it's grown to 6 continents, and we share for an hour our experiences, different speakers speaking about each part of the disease. It's been true in infectious disease. It's true among hospitalists who care for these patients on the floors. And then in our region, we set up a call with the pediatric ICU directors across the state of Massachusetts. We speak twice a week. I mean, it goes on. And the amount of sharing, the amount of collaboration, the amount of teamwork and cooperation is simply way beyond anything I've ever seen. And it's all to good use. We're sharing each other's experiences, protocols. People are not worrying about attribution and credit at this point. They're worrying about quality and using the best data we can. And sometimes these changes can be very difficult to swallow, to be honest, especially for the frontline clinician that on Monday and Tuesday uses this therapy in this order and believes that this is the best way to do it. And suddenly on Wednesday, there's a new rule, a new process, a new drug. We don't use out with the old, in with the new. And it's been a struggle, but an important struggle to remind people to focus with an optimistic view that the reason we change things is because we've learned. And the learning curve in this illness has remained, to this day, extraordinarily steep. And that means that the changes in how we deliver care, whether it's regarding PPE, therapies, whether mechanical therapies, how you ventilate, what settings you choose, to drug therapies, have changed and have continued to evolve. And that's scary on the one hand, but it's really good on the other, because that means that we're applying real-time learning to modify therapy in a live fashion and taking advantage of learnings throughout the world instantaneously.
That's very encouraging. But I imagine, as you say, it is, in fact, scary and hard to adapt in such a real-time manner. The other thing I wanted to ask about, you mentioned ventilators, and I'm wondering whether you're looking at the difficult situation of a ventilator shortage, and how do we think about either ensuring sufficient supply or having a framework in place for making decisions about where ventilators may be used and where maybe they cannot be used if there isn't a sufficient number?
Yeah, it's obviously a big problem and a complicated one. For me, the logistical answer is always the easiest one and the more conquerable one. Although this pandemic is hitting every area of the globe, it is hitting areas at different moments in time. And if we had central coordination, we could take ventilators from a state that is 2 weeks behind and send them to a state that's 2 weeks ahead, and vice versa, and return those and move equipment around. I believe that we have enough equipment in this country to deal with all the patients. We just need to allocate them properly. When we think about ventilators, a lot of the standard counts of ventilators are kind of the ideal ventilators on one particular list. The fact is, every hospital has a large number of other machines that we don't usually think of as ventilators, but in fact they are. Our non-invasive ventilator machines often don't make the ventilator list, but there's 50 in our institution and we use for non-invasive care, but they're actually built to deliver invasive ventilation. Same thing for anesthesia machines. Every operating room has its own anesthesia machine, as do other areas in the hospital. You don't think of them as ventilators, but they are absolutely ventilators. And so some of the counts are much better than they seem. And again, logistical delivery of moving supplies around in the optimal way, it has not yet been optimized, but is moving in the right direction. All that being said, there may in fact be true shortages that come in a given environment. And it is important to stay on top of that concept and have ethical deliberations in advance to set up a structure to think about how to use the equipment in the best way. And there's no question that those conversations are underway. Guiding principles are really focused on the individual situation. We don't want to make broad statements about classes of people, groups of people with a given disease, with a given age, with a given set of symptoms or settings. Those group kinds of decisions are not the way to go, but to look at the risks and benefits in each given situation and try to optimize benefit for the entire society.
Michael, to wrap things up, I'll ask you my wrap-up question. If you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect to find has changed drastically?
The most significant advance that we've made in the past few weeks, and I expect to be finalized and implemented in outstanding fashion, is the delivery of virtual care, both on the outpatient side and on the inpatient side. I think our ability to integrate communications, optimize live communications, video, audio, as well as vital sign data and data delivered from machines and monitors at the bedside, has taken an extraordinary leap in these past few weeks. And if we can maintain, capitalize, optimize those gains, I think we can deliver much more efficient, high quality care going into the distant future. So if we can maintain that, develop it, optimize, I think that would be an incredibly positive outcome. The connections that we've been able to make, crossing time and space between clinicians and patients, collaborations around the world between clinicians from a research and data gathering point of view, care delivery, monitoring at the bedside, those are all potentials that we've had for a long time, and there have been good and not so good reasons why they've not been optimized. But in these past few weeks, we have closed gaps that have allowed us to make leaps and bounds ahead to provide this integrated care. And I think that can be sustained and optimized and will be an incredibly positive result of the pandemic and have a lasting positive impact on the way we deliver care in the U.S. and globally.
Well, there's some silver lining then, I suppose. Michael, thank you very much for taking the time to speak with me.
And a pleasure, David. Thank you.
You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.